And how does data inform our decisions? How does data inform our next course of action? Without data, you cannot be able to make certain decisions. We are in an industry, we are in a country, for example, in Kenya, we have 56 million people. Do you know how many outpatient visits we have per day in Kenya? How many can guess? We have about 495,000 outpatient visits in a day. Do you know how many admissions we have on a daily basis? How many people are in bed today? 15,000 in this country alone. And that data you can spread across other countries. But what does that inform us? What do we need for us to serve these patients? Because if healthcare is not around the patient, there is a challenge to that. The patient outcomes are critical. Data systems must all contribute to ensuring that we have positive, better patient outcomes. I want to just give you a little case here. During COVID time, there was one facility that was really using data, and they realized that the patient outcomes were quite positive for or with a certain healthcare officer, let me call them a doctor actually. And they were saying that every patient that was going through this particular doctor, they were having better outcomes. They were coming out better, rather they were coming out of the issues, within a shorter time, and they realized that they're using particular models or treatment protocols. And what did they do? They went ahead and they now used her to train others. But they could not have done that without data. Data informed them that this particular scenario or this particular outcomes we are having, it's coming from this doctor, and therefore there are certain things they are doing that we probably, some of us, need to learn from them. And I thank God for that facility that they did not just keep it within, they went across the board and they were able to train other doctors. During COVID, same time, we had limited number of, ICU beds across the country. But what did data do to us? It exposed that number to us. And now you could be able to have patients, be referred to certain facilities because there's a vacant, bed in this particular site of facility. So there's quite a lot that has been achieved in this country, but there's yet a lot to be achieved as we move forward. I don't want to take a lot of time because I know my colleagues here they have a lot of amazing tenets that we shall be bringing on board. But I would say that there is no way we can move forward without digital systems, without data which is quality and comprehensive enough, and most importantly, we must harness from that data. We must get intelligence that can help us to make decisions, especially at a time when we have limited resources. Thank you.
Thank you so much. Yes, appreciate him, ladies and gentlemen. And speaking about digital healthcare systems, Benjamin, allow me to bring you in here because AGC Tenwek Hospital has embraced digital healthcare technology. So my question would be, what really motivated the institution's decision to actually embrace the digital transformational journey?
Thank you. Winnie, I really appreciate this opportunity to be part of this panel. Maybe just to set perspective, Tenwek Hospital is a level 5 facility. Recently we had our specialized unit, that is the Cardiothoracic Center, being a level 6B. We are based out in Bomet County. We now celebrate almost 9 decades since it was started. Next year we'll be celebrating 90 years as a facility, and we really thank God. Also, from a mission perspective, we are a Christian facility committed to excellence in compassionate healthcare, spiritual ministry, and training for service. We are such a big center of training for nursing, for clinical officers, for residency programs. So we are big there. And we're really happy that our new kid in the block, that's the Cardiothoracic Center, is actually one of the biggest in sub-Saharan Africa. We just commissioned it over a year, and we've already seen quite a number of patients who come through our facility. The last count that we had were actually from 14 countries, from Southern Africa, Western Africa, Eastern Africa, and we're really proud to be part of that journey. So to the question on the digitalization or the digital transformation, I think what Isaiah has sort of highlighted really speaks into the journey that we've had as AGC Tenwek Hospital. Our journey started in 2000, so we are about 26 years since we went digital in our electronic medical records. And we've really been in this journey. There are quite a number of lessons that we've picked over the years. The initial decision was more a business decision. It was not a clinical. We just wanted to ensure that we have proper billing systems, that we were able to address the leakages that were there in the system, and did not really address the clinical part, of the service. And that was a big learning, because we had not involved the clinicians or the clinical team while developing that solution. So that decision was generally to continue with the excellence. I think we've talked about excellence being intentional. We just really need to be very intentional in what we do. So part of the decision then was really to employ a lot of this digital transformation to help us provide better healthcare, better outcomes, and excellence in everything that we do. So the decision then, after we entered into that, we learned our lessons, because it did not pick up the way we expected. We had to go back to the drawing board, and we had now to address the issues and make sure that we built into the system or into the entire product, as it were. So we had to involve all the stakeholders, understand the workflows, understand what the nurses would like this solution to provide, understand what the clinicians would like this solution to provide, and also even the financial side or the administrative side of things. So that really helped us, because then in 2013, then we had to sort of relaunch the next phase. Which was more successful after learning the lessons, after burning our fingers. And we launched it, and it was quite successful. It really helped us to provide better outcomes, to provide faster turnaround times for our patients, and really helped us to move fast, in terms of where we wanted to be from a strategic perspective. So that has really helped us. We've continued to build that. In around COVID time, we had now to upgrade even higher. And lately, we even integrated some of the latest technologies, the AI technologies, into the system, and it's really helping us big time in terms of achieving our strategy, our mission better, engaging the stakeholders, and making sure that we have better outcomes.
I see. And we'll come back to you to understand some of the challenges, but also the lessons. Like you said, burnt your fingers a little bit, but also learned a lot along the way. But Dr. Joseph, let me bring you in, because now we hear a lot of conversations around data and how data is the new gold as far as healthcare is concerned. So from where you sit, either as Dr. Joseph or as Jacaranda, why do you think data is becoming very critical, and especially when it comes to shaping modern healthcare services?
Thank you very much, Winnie, for that questions, and also my fellow panelists for the insights that these two gentlemen have shared. So I'd like to share my perspective, both from Jacaranda Health, but also from someone who has done engagement and partnerships with different partners. And for this discussion, I would like to more focus on the public sector, because most of our work that we are doing, we're actually working with the government, and majority of Kenyans actually seek care in public facilities. About 60% of Kenyans do seek care in public facilities. So what we have seen actually in Kenya is that data is there. Data is not the problem. But for data to make sense, someone has to sit somewhere and make a decision to use that data and make a decision to invest or to buy something. And for that person to do that, they also must be having the right skills in terms of understanding the data. And in addition to that, they must also be having the authority to make that decision and follow that decision to implementation. And the gap we are seeing is that it's not a straight line from having the data, making the decision to use the data, and actually following that decision to implementation. And why am I saying that? In public sector, the biggest data source is called KHIS, Kenya Health Information System. And that system basically gathers service statistics. And what do we mean by service statistics? As Isaiah was saying here, that data is able to let us know how many people came to a public facility or private facility and how many people did they serve. So just giving, not a specific figure, just a guess. Assuming that within our public system we wanted to serve 1 million patients. KHIS will tell us we saw 700,000 people. So it will tell you how many people were you able to reach, how many people were you able to serve. And that's a good indicator because you can start asking yourself, where are the 30% that we did not serve? So that's helpful. But that's not all the data that we need, as Isaiah was saying. We need to move beyond just seeing the statistics we are serving to actually what can be used to make decision and improve care outcomes. Because for every single person who comes to the facility, what we want to do is to make sure that they have a good outcome and they go back to their families. So what are some of the data we are missing from KHIS? Some of the data we are missing is actually this person who came to facility, did they get the care that they needed and did they get the service that they actually needed? If they came to a facility for malaria treatment, KHIS will tell us, yes, this person came for malaria treatment. But did they get the drug that they needed? Were they treated with respect? And what did they get? So we end up missing that data. And we have seen that data being very important, very needed, but it's not available. So what we have done at Jacaranda Health is that we have come up with a digital SMS system, basically functioning on SMS. And what is it doing? It's collecting that missing point of data. So what are we collecting? And this is working in the maternal health space. We are asking women when they come, and moms, when they come to seek care, we are asking them, did you receive the care or the services that we needed? Basically, I know a number of people here know about ANC. So we're asking, yes, we know KHIS is telling you as you came for ANC. But actually what happened when you came to seek that ANC services? Was your blood pressure taken? Was height and weight taken? Was blood sample taken? And those are very important data points because they help us know what is the quality of care that our clients are receiving. But most importantly, the other thing we are asking them is, were you treated with respect? When you came to seek this service, were you treated with respect? They tell us yes, they tell us no. And we are able to use that data to speak to county partners, to speak to government, and identify opportunities for improvement. And some of them are very simple. For example, a mom told us in one of the facilities, there were no blood pressure machine where he went. And it was as simple as moving blood pressure machine from point A to point B, possible within the facility. Some of them require investments, like we need to extend the wing, we need to add benches and so on and so on. And sometimes health service providers do not have that. So basically what I'm saying is, yes, we have lots of data as a country. Sometimes I think we have actually more data than we need. But basically what we should, the question we should answer is, are we getting the data that is helping us make the right decision? And are we availing that data to the right people who have the power and authority to make decision? I want to finish with one example. How many of you know how many mothers we are losing daily in Kenya due to maternal mortality? Anyone? We are losing about 16 mothers every single day, 365 days a year, every single day. That's the amount of mothers we are losing. And yet, we have never had a national discussion on, this is a tragedy. This is a whole 14-seater matatu crashing every day and losing everyone. We have never had a national discussion on such a data point. And one of the reasons is we do not present this data to the right people in a way that they can understand it. Actually, it took the president to move out of this country, to go and sit in a conference, and someone who is not a citizen in this country, presenting that data to him and telling him, we are losing 15 mothers every day in Kenya. And that was last year. So when he came back, he started the discussion about how do we help and stop our mothers from dying. And yesterday, he launched an initiative called Ewene. Every woman, every newborn, everywhere. Basically aiming at reducing these maternal deaths because it's unacceptable. How long have we known this? This data was collected in 2019. This data was collected in 2019. But we have never presented it in a way that the policymakers and the right people would get to know and implement or make this a national discussion. So what am I saying? Yes, we have data. There's data that we need to collect and present in a way that is understandable. But we're also having a lot of data within us, only that we are not using it as we should. Okay. Thank you.
I see that. And even yesterday, during the conversation still on the digital systems, a conversation around data came up very strongly, that we have no shortage of data. But then again, on the flip side, we always hear there's no data, at the same time. And I'll come back to you to really interrogate, why haven't we been able then to present it in a way that should have been presented so that we translate that into actionable into action rather. And Joy, I think this is a question for you, speaking on translating data insights into actionable policies and scalable healthcare solutions. Why have we failed, or why do we often fail to really translate, data, whatever data that is available, into action?
Okay. Thank you to the rest of my panelists for the interesting conversation so far. So I'll just step back and look at it not from data. Data is there. Data, numbers are there. But what we should be thinking about is insights. What exactly do we want to know about our healthcare system? Are we sitting back and thinking, I need to know, for example, how many mothers are doing the 8 ANC visits or 4 ANC visits as it was before? Then I go back and see, where can I collect that information from? So first, standing back, figuring out for my healthcare ecosystem, for example, in Nairobi County, what is it that I need to know that healthcare is actually working? If I'm in the private sector space, what is it exactly that I need to know that people are able to access healthcare when they need it within a certain time period? So first, it's looking at insights, stepping back and looking at what do I want to know and how do I get that information. So for data and insights to make sense, they need to be embedded into daily workflows. So for example, if you're looking at the billing cycles, for example, that Tenwex started, when they started with digitizing the process, I think there was a need for making the billing cycle more optimal so that you don't leak money and such like things. You know where money is going to, which services need to be funded better. So there's a need that was identified earlier on. Then you go and figure out what systems need to be embedded and what information needs to be collected. Then you go now to the clinical side of things and figure out that, for example, mothers are we're having a terrible mortality rate for mothers. But how do I interrogate that further? What delays are causing this mothers from accessing care when they need it? So how do I go and figure out that an SMS system, for example, is what I need, just a simple thing for people to come back and tell me how their experience was when they went to hospital. So those are two things. If you embed, make sure that data and digitization is embedded into your workflows. You're not just caring about the reports that you're going to send at the end of the day or at the end of the month, but it's something that you care about daily. Then it becomes more of a routine process that you're every morning, as for example a clinician or as a finance person, I want to look and see, I want to get insights, not to look at a report, so that I can be able to make changes within my operations earlier on, make interventions earlier on that will make changes within the ecosystem that I'm building. So in short, what I'm saying is let's step back and not look at it as data. Look at the healthcare ecosystem more broadly. Look at who you're serving and what sort of information do you need to be able to make more better decisions for your operations.
I see that. And we'll also talk a little bit in terms of then the interpretation of the data, because sometimes once you receive that data, how do you interpret and what do you do based on the insights that you have received? So we'll unpack that in just a second. But Dr. Olwit, just to bring you in here, because when we're looking at improving treatment outcomes through data-driven decision making, would want to really understand first of all the role of data-driven decision making in improvement treatment outcomes, but at the same time also speak a little bit on precision medicine changing treatment outcomes as well.
Thank you, Winnie. Thank you, Winnie, and the rest of the panelists. I think you've painted a very brilliant picture of what and exactly how data helps us as clinicians and healthcare practitioners to serve the public. And I think that's the main reason why we're here, is trying to see how exactly can we use data to improve our health outcomes. And if I speak directly about, in particular, what I do in my field and what most of the practitioners do as relates to precision medicine. So when you think of precision medicine, you think, how can I make this care that I have personal for my patient? And what that entails is right from a few pillars. So the first pillar is diagnostics. So how can I diagnose what's wrong with this patient? And I want to make it specifically targeted to my patient. And after I've got an idea of what the imaging looks like, what the pathology looks like, so that may mean sending them to do a CT scan, sending them to do an MRI, and then sending the person to the laboratory to get a blood panel or maybe a tissue biopsy or a sample of some sort to tell me what the primary disease is. And with that, instead of looking at it as a one-size-fits-all, so this patient, go do an X-ray, go do an ultrasound, go do an MRI, instead it's what exactly does the patient come with that I need to tailor my diagnostics and my care for that particular patient. So while most of the data that we have and all the aggregators that we have are more general in terms of public health outlook, precision medicine is looking and saying, okay, I have patient John who has come to the hospital. How can I, Dr. William, tailor my care particularly for him? So those pillars of diagnostics, therapy planning, and prognostication plus follow-up are all tailored to a particular patient. And what does it mean for us as a nation and as a healthcare practitioner? So it means that instead of creating a treatment plan that looks like malaria for one patient, go to the pharmacy, get this, one pill, take it 3 times a day, and after 3 weeks, do a repeat test, we'll see what's wrong. You'll notice that in public health and with health, the current trends, the human evolution, the economy evolution, the different trends that are currently going on, we've shifted away from having infectious diseases as being the main burden of healthcare to now non-communicable diseases and more in particular cancers. So what that means is we're moving away from acute care to more chronic care. And chronic care has a very high economic burden on the patient, but also on the government. Because a patient who suffers from, say, colon cancer, the diagnostic costs are quite high. The costs of treatment and management are also quite high. And the costs of prolonged care throughout the patient's life are also quite high. And so in precision medicine, we try and tailor the treatment, the diagnosis, and everything that surrounds that patient such that we limit unnecessary redundant testing. We limit trial and error therapies. So instead of saying, oh, let's try this chemotherapy for this patient, let them take 6 cycles and we'll see if after 6 cycles they're better. We say, no, we're going to use the data that we're going to aggregate for this patient, meaning I will send this patient to do a PET scan. Okay? A PET scan uses specific radioactive tracers that we inject into the blood that go directly to where the cancer is. And so we're able to image and say, this patient has this type of cancer, okay? And this is the primary site. And now the cancer has spread to the lungs, the bones, but maybe it hasn't spread to that patient. So in my patient, John, who has come to me, I'm able to identify the extent of disease they have and say, this patient has only localized therapy. So what does that mean? That means this patient does not need systemic therapy. So I'm not going to put him through an intense toll of medication that he doesn't need. I'm not going to send him to do an X-ray and a second MRI. I'm not going to send him to the laboratory to do an unnecessary panel of tests that he doesn't need. My care is going to be specific. Go do this surgery, remove. After that, I'll do a follow-up PET scan and see if you have any residual disease, and then plan my therapy around you. And unfortunately, because of the discrepancy between healthcare practitioner numbers and patients, it's difficult for us to create personalized treatment plans for all our patients. So where does data come in then? Okay, and where does AI come in then? So me as a practitioner, it's very useful for me to have an AI assistant, to have a data-driven tool that I can use to help me prioritize, 1, patient diagnostics, patient prognostication, and patient follow-up and planning. So I'll use the example of where I work, my center, the Nairobi West Hospital. We have AI-powered PET CT scans, AI-powered MRI and CT scans. So what does that mean? If I scan 60 patients in a day, maybe 40 will have no pathology. But I still have to look at all the 60 scans to decide. But using a data-driven AI-assisted tool, I'm able to triage and pick out the patients who have a higher burden of disease, prioritize those patients, then use tools such as genetic profiling and molecular imaging profiling to sequence the disease that has been taken from the biopsy and say, okay, this disease, the immunohistochemistry profile states that it has this receptor X, receptor Y. So those receptors are more receptive to treatment X, a specific treatment. So for my patient, John, I've triaged, I know exactly what disease he has. I've built a molecular profile and an imaging profile based off of the data that I've collected from the hospital. And I'm able to create a treatment-specific plan for him. And I will follow him up and get predictions from either an AI model that we've created for him, specifically for him, based on other comorbidities that he may have. Maybe he has diabetes, he has hypertension, maybe he also has a history of smoking. So I create a risk profile for that patient. I create a treatment plan for that patient. And when I begin my treatment with this patient, they know that my doctor is really taking care of me. They're not taking care of 600 other patients. It's for me. And that's the beauty of integrating AI into our practice and integrating data utility into our practice. It helps us create these personalized treatment plans. And that, as a whole, helps improve the specific outcomes for our patients. Allow me to end by, when I was being introduced, you asked me what theranostics means. So theranostics is really at the forefront of precision medicine. And why I say that is we all, I'm sure, have heard of cancer or had an experience with a patient who's had cancer. And I think you all know the burden that chemotherapy and radiotherapy place on the body. So theranostics is not something new, but something that's recently become more prolific. And what it really means for us is I'm able to take a radioisotope, and a radioisotope just means something that has radioactivity, not the bad radioactivity, the good one. So not in nuclear bombs, but the ones that I can put in your body and I'm able to use it. So I'll take a radioisotope. For example, I'll use the case of prostate cancer. So prostate cancer has a receptor called prostate-specific membrane antigen, or PSMA for short. So I'll take a radioisotope and tag it to that specific protein called PSMA. I'll then do a PET-CT scan that targets PSMA. So in this patient, I'm able to see all the disease light up on my PET-CT scan. And that PET-CT scan will show me all the sites of disease. Then I take that same radioisotope and I tag it to a radiopharmaceutical with an increased amount of radioactivity. So because it's very specific, it will only go to the sites of disease that the patient has. So what does that mean for my patient? It means I don't have to affect the patient's entire body with unnecessary treatment. So it's very targeted in that I see exactly what I'm going to treat and I treat what I've seen. So that's the whole principle of theranostics. We see what we're going to treat and we treat what we have seen. And that's something that we've done for patients with prostate cancer, patients with thyroid cancer, patients with other neuroendocrine tumors. And it's something that we're doing at the Nairobi West Hospital, and I know a few other centers in the country that are also doing it. Unfortunately, as with all things, we're limited in terms of specialists. I don't think anyone here knew what theranostics was, but at least now you know. And that's one of the ways that precision medicine is actually helping to help us with chronic care and oncology care. Thank you.
And that's really, really good to know, because sometimes people would want to understand then the balancing, because patient care is not just diagnose, give medication and then follow up and then that's it. There's a whole lot of things. But then when it comes to balancing the business side, of healthcare and the patient care, we'll come back and really unpack that in just a second. But Isaiah, allow me to bring you in now, because when we're looking at leveraging analytics to improve outcomes and efficiency, what are some of these emerging trends in healthcare analytics do you believe will shape the future of healthcare delivery?
Thank you very much for that question. Just to step back before I answer that question, one of the things we've seen, especially in Africa, the markets we are in, is embracing especially data insights to make decisions. I think it's still foreign from the interactions we've seen or we've had. And that's why sometimes you find even healthcare facilities, some of them may not invest. You say, I can't invest 200,000 shillings. But yet, the impact of that, just 200,000 shillings investment, is going to be probably into the millions. So that's the culture we have come in from. But one of the things we have seen as a trend for those who have embraced data analytics is basically use of modern tools. And the use of modern tools here, comes from the basic Microsofts all the way into some of the tools I may not be able to list here. But they are very extremely helpful. We have seen scenarios where through use of analytics and data, where, for example, healthcare facilities have been able to model their processes internally. They have had to change some of the things they are doing. Some research was done a couple of, I think maybe 2 or 3 years within this county, within this city. And it was noted that one of the facilities, high-end facilities, was, if you look at the average inpatient stay, was 2 days more than every other party. And that was a question. How come we are making our patients stay a bit longer than the rest of the people? They came to realize not the doctors who are not doing the job, it's not the nurses, not, they just came to realize they don't have resident doctors. So they cannot release you from the hospital because the doctor who admitted you is not around. They are in Kisumu, they are in Mombasa. They have to fly in for them to discharge you. And they have to change their processes. And that's why I agree with Dr. William that indeed, how do we use healthcare digital systems to serve the underdeserved or people in the marginal areas? Right now, with such tools, you can be able, as a specialist, because we have few of them. Actually, the ratio right now in Kenya is 1 to 10,000. The WHO recommended is 1 to 1,000. 1 doctor to 1,000. But we are 10 times insufficient. That's a scenario we are in. And not just for doctors, but you look across the spectrum of the healthcare facility practitioners that we have. So we have limited resources, but we can leverage on digital platforms. We can leverage on analytics for us to make decisions or for us to utilize, for us to optimally utilize the resources that we do have. But allow me to just indicate this, because if I miss it, it will not be good for us. There is the issue of us having data. That's one thing. But there's the issue of us having the right data. Having data is one thing, and I can tell you we have terabytes and tons of such data across the country. There's one day some organizations were presenting data before donors. By the time they finished, everybody in the country was already dead. Through that data. Because it's just disjointed, it's everywhere. But if we can have that data, 1, be comprehensive enough, 2, be accurate, 3, be integrated. That's when we can make decisions. At SMART, we have data for about 5 million visits, about 6 million visits in this country. We control about 70% of the private insurance corporate members. And therefore, we can now be able to tell some of the aspects that are affecting our country. And the question is, how can we, for example, make policies or decisions that will help the country? 38% of our spending in this country, as far as healthcare is concerned, is on medicine. But how much is manufactured locally? Somebody give a guess? Right? It's less than 5%. So those are the things that we need to look at and say, what does this data tell us and how do we improve on that? Maybe just to finalize before I give it back to you, is that first we need to embrace the digital platforms. That's very important. Secondly, we must then utilize them to inform our future, the decisions that we must make. We must be able to do that. And that's when then we can talk about intelligence. Intelligence only comes in when you have now converted your raw data into information, and it has been able to tell you, what do I do? We have limited resources in this country. As Dr. Williams said, for example, we have few of them, maybe, for example, in this city, but he can be able to serve more. He doesn't have to physically be there. You can be able to access. So just before I finalize that, one of the things we're also doing is that we have provided analytics based on the data we are talking about, based on the 5 million plus visits that we see across the country, and we are able to advise healthcare facilities probably what kind of services do you need to have in this facility? Where do you need to extend your services to? How do you probably cost? Where do you have wastages? Because we have noted that whether you like it or not, what you have seen in the industry right now, 35% of the doctor's time is on administrative things. And they were not created to do that. 35% or more. A doctor is supposed to look at my case and give me treatment. But you realize they're shuffling through papers, through devices, through computers, through every other thing. At the end of the day, then we have that risk of them not giving me quality service. All systems must be patient-centered. Patient outcomes are critical. Without that, you may not be able to provide that service that is needed. Thank you.
I say that, and Benjamin, just to bring you in on his point, because yesterday still a conversation on AI and how that should help when it comes to offering quality care to the patients. One of the speakers said, let's not get excited about AI, that AI is here, but we need to figure out, because whatever is being fed, is not from the country or the region, it's from the Western world. So we need to, yes, get excited, but also get excited about our own and what we're feeding into it. So I'm curious to understand from Tenwek, how you're able to, yes, embrace the power of technology, but also empowering the workforce to ensure that, yes, they leverage the power of technology and, and AI, but at the same time from a point of information and not just, let's test it out and see, does this work, does it not work?
Thank you. Thank you for that. So for any technology or any transformation to happen, it really needs a lot of support at particular areas. So one of the areas that is critical, and I think I had alluded to it, is as you design the system, make sure that you really include all the stakeholders, so that across the chain, it addresses the challenges that they have. The other big thing is, and that was also a learning point for us in Tenwek, was the infrastructure, investment in the right infrastructure. Because if it takes long for a nurse to get certain data, that is going to aid in terms of the treatment of the patient, then the only rational thing is then to regress back to the paper information or the paper data, and that way then we are going to lose on the adoption or the uptake of the technology. So we really need to make sure that the infrastructure that we are investing in, that we are providing, is actually aiding and helping the teams. The other one is the role of leadership, in the entire chain, because once you deploy the technology, then you really need to believe in it as leadership, and even within the various departments, the various cadres, so that we don't leave it to the teams in those departments. You really need to get interested when you go there. How is it? How can you support them better? Do you understand the challenges that they are going through? That way, then they'll embrace it better, and that is going to have better chances of being taken up. The other one is sometimes we need to be intentional in the parallel systems. Because if we have adopted the digital systems and we have again the paper systems running at the same time, then the natural thing is then people will just go back to what they were used to. So we need to be intentional in terms of removing those parallel systems, so that you make people adopt, engage, and maybe share whatever challenges that are there, that are inherent in those systems, and have them addressed, so that then you can go forward quite faster. I also want to, I think the other learning point and is the need of capacity building within the system. You really need to build the capacity of the staff, and if possible, before employment rather than after. So we, like I said, we are a big center of training, and some of the skills that we are deliberate in terms of building that they may not necessarily be in the regulator's curriculum is actually building these digital skills to the students. So if the nurses, if the clinicians can be able to be trained ahead of time to understand these skills or these areas, then it will really help in terms of the adoption and moving forward. So I think we just need to influence even the curriculum developers in the regulator space, so that they can really help the transformation that is expected within the sector. So those are some of the areas that really that we picked along the way, and it really helped us even as we continue to progress. On the issue of data, for them to to really see the value, because they collect a lot of data, they actually feed into management or into the leadership to really help make certain decisions. They need to see that the value of the data that we are collecting is helping management or helping decisions to be made. So don't just get the data, but continue using it and even giving them feedback, because the moment we present, sometimes we have presentations like the trends of this unit is either going up or going down, then they may be like, we need to go back to our data. There seems to be a problem in our data. And that way, next time they'll actually make sure that the data is accurate, the data is complete, and that it's actually depicting the right trend, as it were. So when they see a lot of that, then they'll actually continuously build the credible data, and the utilization of the same is actually going to help big time for decision making.
All right. Thank you so much, Benjamin. And Dr. Joseph, let me bring you in now, because what we've seen for so many African healthcare systems, when we're looking at data quality, and fragmented systems, this remains a very, very big challenge. So I'm keen to hear from where you see some of the practical steps that institutions can take to really improve this, and especially when we're looking at maternal, care or newborn care.
Thank you very much for that question. And I just want to pick it up from where my former speakers have said, and the AI discussions and what AI can do. So AI is actually not the standalone solution. Actually, AI by itself is not the solution. AI is simply helping healthcare workers, everyone in every sector, to accelerate what they would have taken ages to get into. For example, specialists, if they were to move from point A to point B, they can only see a small number of people. But AI can accelerate how much people you would be able to see in a day, for example. And a good example is what we do, because our digital SMS solution is per year enrolls about 700,000 mothers. And one of functionalities of this SMS is they're able to ask questions about their pregnancy and ask questions of any concern they have. So per day we are receiving about 15,000 questions from these mothers. 15,000 questions, you can imagine. So how many people would you need to satisfactorily respond to those questions and meet the needs of all those mothers who are asking us questions daily? Probably we would need more people than we have in this room every day to respond to these questions. So AI is helping us actually respond to all those questions by having about 10 people in our organization. And how is it doing? So the first thing we have to get is, in all this haystack of questions, 5% actually indicate that someone is in a danger sign, or someone is having a danger sign. So for example, they're bleeding. Someone in rural Homa Bay is bleeding, and they have said, bleeding, is it normal? So you can start responding to the question about when will be my baby start walking. Start responding to that, and then respond to the danger sign question when you reach at it. You need this danger sign question to pop up first and respond to that first. So AI is helping us to identify that, and in 15 minutes we are able to reach, call, and link that woman in to care. So if we were to do it, it's humanly impossible to identify that one questions in another thousands of questions and respond to that timely. And that's the reason why I am sharing that AI is helping accelerate the problem. To your question on how can we improve quality of care, the technologies have different ways of assessing or helping human people address the question of quality. Still to the same example is using AI to make sure that actually the questions that we are responding to the mothers are of quality. So how are we doing it? As the questions come in, AI auto-populates a response to that specific mother, and does also actually keeps a record of what questions has this mother been asking. So the response that is going out to this mother is very specific to their needs, is very specific to what they have asked us before. Before that question goes out, that question is actually also passed through another AI system as a triage. Does this, and we have set it out such that there are those markers it will check and ensure that does this meet the quality standards that are provided for by government before it's being sent out. So we ensure that it's okay. 15% of the responses we have do not meet that standard, so 85% of the responses are actually quality and can go to the mothers and they can address to them. But also when we are working with AI, the other thing we have to make sure to provide quality care, get quality care, and get quality data is to make sure that we are not leaving the human in the loop. There must be somebody somewhere. So what happens to the 15% of the questions that do not pass the quality checks by AI? So we loop them then to the 10 people who I mentioned, then they are only checking about 15% of the questions, and then they can talk to those people. And the other step we do is also to make sure that we are asking the mother, when we send the questions to them, we are asking them, did we actually answer your question? And what that is aimed to do is to make sure that we are not letting machine talk to humans. So a mom would read, they had asked questions about, is it okay to eat avocados? I don't know what is it with avocados. We get that a lot. So if she feels that question that response does not answer a question, then she says no. So when she says no, then that is linked to a human, and they read the question and they're able to respond. So what am I saying? My response is majorly on how we are using technologies to be able to provide timely care, ensuring that is quality, but also not leaving the human on the loop. Because that's very, very, very important. AI will never eliminate that feeling you have when you sit next to a human being and explain how you feel. Because AI will not get that. It's trying to express emotions even now, but there is that special experience you get when you go and sit with somebody. All of you know what the experience was during COVID and not being able to socialize. So we can't eliminate that. That has to be part of it.
Yeah.
Thank you.
Let's AI compliment Ori. But there was someone yesterday, I don't know whether he's still in the audience, who said, you walk into a doctor's office and they don't even smile at you. So I think that goes to I think someone talked about empathy, not just diagnose and give medication and leave, but also empathy is very important. And Joy, you talked about not just really focusing on the data itself, but the insights that you get from the data. So my question to you would be, can governments and healthcare institutions really collaborate more effectively to ensure that we don't just share data, but also what the data tells us or informs us as far as insight is concerned?
That's a good question. So traditionally, I think what has been happening is healthcare institutions have been sharing data to government, KHIS and such like things, but you're not able to get back data in what it means for you as a healthcare institution. And I think there's a lot of opportunity for both stakeholders to collaborate better. So for example, if I'm told as TENWEC, there is mandatory reporting on certain indicators, what then do you expect the government to come back and tell you from the reporting that you have done? Yes, you're able to see on a global level, for example, if there's an increase in maternal deaths in a certain region or in the country, for example, you're able to see that. But since we have always been reporting aggregated data, what does that mean to you as TENWEC, for example, to you as Jacaranda, for example? So getting that flow of information back to healthcare facilities from government or from whatever reporting institution, wherever you've been reporting your data to, is something that is important. I think what is also charged to us as healthcare institutions, or those of us who are working in private sector, for example, let's say SMART and Savannah Slade. We all collect information from all these healthcare facilities, or data passes through us. But how do we go back and shape the thinking, or shape the healthcare ecosystem, not just waiting on government to do something and tell people about information, but even as private players, how are we sharing back information so that these healthcare, the system strengthening is happening? We are all treating the same patients. For example, someone from Tenwek can later on visit a Jacaranda facility, for example. But how do we identify that this Joy who went to Tenwek 3 months ago is the same Joy who has come and is now pregnant and is going to deliver around where Jacaranda is? So that flow of information, for example, SMART, you'd be able to know that this is the same Joy. On Slade, you're able to know that this is the same Joy who has gone for multiple care episodes, and link that together and be able to tell a story of how healthcare is being accessed and such like things. Then when you go into the clinical side of things, you want, especially now that we're getting into a lot more cases of NCDs, cancers, diabetes, hypertension, and all these things. You need to track you need to track individuals even before they become patients, so that you're able to let them know about how to take care of their health better. So through communication, through SMSs, USSD, workflows and such like things. So it's not really depending on government to tell us what is going on in our ecosystem, but even us as individual stakeholders within the healthcare space, how are we sharing information so that the ecosystem is strengthened? That's my view.
Build more on interoperability of of the systems. Ladies and gentlemen, we're edging closer to the end of this conversation to give room for the next panel. So for those of us who have questions, I think we'll have room for 2-3 marks questions. So if you do, please raise your hands. We'll have a roaming mic come to you. But even as we do that, Dr. William, because like you said, precision medicine it's important, and especially when we're leveraging on the power of AI, I'd say. But when you're looking at the future, what are some of these technologies that could really most transform personalized medicine and treatment outcomes?
That's a very interesting question, but it's also very loaded because it's asking me to be a prophet. But what I can say is, just like what Joy has literally just said, we have to see a way of getting to these people before they become patients. And what technologies can we currently harness to help us bridge that gap? Unfortunately, in current practice, you and a lot of healthcare practitioners will attest to the fact that most of the patients that we see are often late stage. Either it's late stage cardiac disease, it's late stage diabetes with complications all over, it's late stage cancer that is stage 4, which has spread all over the body. And even in the case of maternal medicine, that matatu full of 15 mothers who are dying every day, it's mostly because the earlier diagnosis is not happening. If you look at the distribution of just the current technologies that we have available, all health centers that are doing maternal, prenatal advice and checkups should have, at the bare minimum, an ultrasound scan. And with an ultrasound scan, you're able to identify high-risk mothers, categorize them earlier, refer them up the chain of treatment, so that then, by the time they get to delivery, you know who is at a higher risk of getting complications that would lead to a maternal death or to neonatal prematurity or any form of failure. And the current technologies that we have can help us in a plethora of ways, but one of the most ones is early diagnosis. And so things like chest x-rays, routine chest x-rays for screening purposes, mammograms for women who are both high risk but also at an age risk, to screen for early detection of breast cancer. Because if we get these diseases at a stage where it is T1, T1 is what I would categorize as very easily resectable with no risk of residual disease. So if we can find them at that stage, there's a higher chance of having better outcomes for this patient or for my relative or your family member. I feel when we talk about patients as patients, it becomes abstract. But these are people who are related to us, who are us. And if you think about it in that way, then even as a government, the pressure to intervene and to put in place the political will to make these changes and use these technologies that are being driven helps us. So for bridging out these technologies, and if I was to predict what I think is a better outcome for us as Africa, as Kenya, and to, as our theme says, position East Africa as a center for healthcare excellence, we have to think in a few pillars. So the first pillar, of course, is how do we get to the patients, to the people before they become patients, and that's through screening. So screening as a tool means I look at you, you don't have any disease, but you come and do regular checkups. Okay? You'll have an annual health checkup that includes a particular screening for either breast cancer, colon cancer, prostate cancer, anything of the sort. And that can be through imaging or through lab work. And using these data-driven tools that we have, these data aggregators of coded, clean data that is based on our population, we're able to build AI models and data models that can help us serve the greater population through screening tools. In some work that we did with the WHO, we set in place CAD, which is computer-assisted diagnostic tools. We set in place guidelines for what can be used in an African population. And that means the data sets that are used should be from Africa. They should be from our population, because we have a plethora of conditions that may mask disease. So screening is the number one thing. The second thing is tools that will help us to characterize disease and build risk and prognostic profiles for our patients. So that means tools like what we have at Nairobi West, which is the AI-powered PET CT scans. So what that helps with, if I'm an oncologist and I see a patient now who has prostate cancer, I send them to do a particular test. And that test helps me build a patient profile that tells me this is the burden of disease, this is what this patient is most likely going to respond to in terms of treatment. So that means I know not to tinker around with different chemotherapies. But also, after I've treated this patient, the third thing is now, how can I evaluate a response to treatment? And we have tools for that as well. So we have MRI, we have CT scan, we have PET CT as well, we even have X-ray. But if for example, I will see maybe 100 patients plus in 2 days. Okay? That's a lot of work for one human brain.
Sure.
But a designed AI-assisted triage and follow-up tool will know that this is patient John, whose identity number is 444. Okay? And it will look at all the scans that my patient John with identity number 444 has received before and after treatment. And that means I'm able to map out what has changed. Has the disease shrunk? Have some sites disappeared? Or is he progressing? And that means I can escalate or de-escalate my therapy targeted to my patient. And I think the use of all this 5 million plus data that we have that is tailored to our patients will help us to build those models so that we can more specifically manage those patients. And after we've done surveillance, the last thing, we've treated the patient, they're okay. But 1 year down the road, I want to make sure that same patient is not going into recurrence. So the tools will also help us to know that, yes, I come from Mombasa. I don't have to travel to Nairobi to do a repeat PET scan. Okay? I can do my PET scan from Mombasa. Okay? The AI aggregated tool will be able to flag and tell my general practitioner, hey, Dr. William, who is seated in Nairobi, has looked at this patient's PET scan, the data that you sent him, and he thinks that there may be some recurrence here. So please call the patient in from wherever they've come. so that we can intervene. So what that means is, one, we're able to intervene early in our patients so that we treat them before the disease becomes very morbid. But we're also able to evaluate our treatments to make sure that they're working and they have a response, and also keep them under surveillance to make sure they don't trigger. And I think with the use and the aggregation of data models that are built for us and by us, and the integration of the novel imaging modalities and also pathology modalities, and integrated electronic medical records into a national health aggregated framework will really help transform our healthcare system, and that's something that we should be building to. So hopefully with government backing, with key partner collaborations, that's something that we can look towards building. And whenever I go for a conference to speak, everyone is really overwhelmed by the amount of data that comes out of Africa. Because if you go onto PubMed and you do an aggregation search for papers out of Africa, out of Kenya, there's so much that we have. But what always lacks is the integration phase. What are we doing with that data? What are we doing with the models that we build, that we have? Is there anything that we're doing, like Joy has said, in terms of insights? Yes, we have 15 mothers passing away every day, unfortunately. What are we doing? Do we do an RCA to look and see what the cause is? How do we build our implementations? And I think that's what we should be starting with as the technology builds and helps us.
Keeps advancing. Thank you so much, Dr. William. All right. 2 questions. All right. So I see 2 hands, 3 hands over there. Do you have a mic? All right. So it's way at the back. Let's see how fast you can run. But please don't trip. Yeah. So we have 3 questions right at the back. All the hands are at the back. And please keep your questions very short and straight to the point, and tell us who yours. Oh, I didn't see your hands. Okay. Keep it very short, really, really short, because in the interest of time, and I can see Dr. Diana is already here, ready for her panel. So start with your name, please.
Okay. My name is Michael. So I have a question to...
Closer, speak closer to the mic.
Okay. My name is Michael. I have a question to Dr. Joseph. So do you think that AI is bringing slackness or laxity? So you feel like you have AI, you can ask a question. For example, if you have a flu or something, you don't have to go to the hospital. You just ask AI, then it prescribes you a medication.
All right, so this is from a patient perspective, not
Yes,
a healthcare
yes.
perspective.
Yes.
Okay, I see that. Thank you very much. All right. Okay, let's answer those ones and then we'll come to you. Okay. Just one question, very brief.
Good morning. Betty Christine is my name. Licensed nutritionist. My question goes specifically to Mr. Isaiah and Joseph. Now that you have this app, collecting this data, how has the data you've acquired been of use in advising policy guidance in both maternal health, also for SMART generally? Have you used any of the data to advocate for policy changes to improve in our nation?
Thank you. All right, there's another hand at the back.
Thank you. My name is Dr. Benjamin Wafula from the Kenya Medical Association. What are the strategies that have been put in place to ensure that we have data protection? And number 2, what are we doing to ensure that we don't over-rely on AI? And then the last one on the last question on precision medicine. Sometimes we might be having a specific, like now you mentioned the prostate-specific membrane antigen that's usually find the prostate, but sometimes it might be on healthy cells and tissues. What are the strategies that are put in place to ensure that as we target with the radioactive substances, we don't in place harm the normal tissues, especially in the salivary glands and the tear glands? Thank you.
All right, okay. You asked 15 questions in one. There's a lady, yes, a lady, yes.
Thank you. Good morning, everyone. My name is Judy Mumbi. I'm an advocate of the High Court of Kenya and also a specialist in healthcare and technology law. So I also run a consultancy on health and technology matters. My main question is, from what I've observed, from what I've studied, from what I've done with different people from Google to AWS, from the US back to Kenya to Europe. And first, they are impressed by how much Kenya is doing from all the technologies we are implying in the country, all the data we are collecting. And I'm happy to be here because, as Dr. I think Benjamin was talking about, Tenwek doing all the work with the technologies, how Nairobi West Hospital is working with so many technologies. I had conversations on how they're using SMS solutions to address, say, maternal health care. And as we do all this, the question that always arises is, if they use, say, generative AI or agentic AI in their responses, and say a mother relies on the same, and liability issues arise, how will the doctors, the hospitals, the healthcare providers, and even the product developers try to evade liability? So those are the questions we've been having all through. How do you use your data? I like the question on data protection, because that's what we have to ensure as policy and regulators, that you are making sure you are compliant with both local and international laws, including the Food and Drug Agency and the European Medical Agency. Thank you.
All right, thank you. Okay, and we had a hand here. Is it like, okay, so we have a hand here at the front. Do you want to stand so that she sees you? Yeah. Keep it brief, please.
Okay. My name is Francis Tofiko. As I said earlier, I'm a clinician. And my question goes to Isaiah. Maybe, do you see any need that we are going to develop a new curriculum towards training the nurses and clinicians, now that we have the AI coming in place all over, giving the diagnosis and the management part of it? Thank you.
All right, thank you very much. Let's take those. And if we can answer them in a minute or less, that would be really appreciated. Benjamin, do you want to start?
Thank you. Maybe I'll go straight to what Judy has raised, and I think they are really valid. That even as we get into this space of technology and the digital transformation, I think there are certain emerging issues that we continuously need to address. Because there are legal issues, there are legislative issues, and the way you've really put it, that we need to comply with the international laws. So I think for me, we need to continue with these conversations. I mean, having people like you, to really help us, then how do we navigate through some of these challenges that are emerging, even as we try to exploit the technologies, I think will really help shape the direction of these technologies and these solutions that we are providing. So even the issue of data protection, I think that's big. Even as we were trying to roll out these, then the legislation and the laws on data protection and the rights that accompany them continue to be something that we need to navigate and make sure that we have compliance mechanisms within those. So I think this is the right forum, and conversations like this will really help us to shape the future. Thank you.
Thank you so much, Benjamin. Isaiah?
Thank you. I'll answer a couple of questions. One is about what we are doing in terms of informing policy. We are working very closely with KEPSA. KEPSA is the private arm of business. And under KEPSA, we have what we call KHF, Kenya Healthcare Federation. We are members, we are active members in KHF, and we do share with them the insight that we do have periodically. Even as recent as last month, we had a forum where we were able to share what has been ailing the country in our summit. And in that particular convention, we had the Ministry of Health, we had partners from the private sector, we had even international organizations with us, and therefore I would just assure you that information is seeping out to the relevant parties, and we are active participants in acts that come around or policies when they're being formulated. So all parties there, we are consistently working with them. Actually, should be watching out, because not a month that ceases without us releasing some form of data insights that help parties to make some of the decisions that they need to make. Beyond that, I would probably address the data protection aspect of it. It's very critical. We are in a space where the data we have is extremely sensitive. You cannot joke around it, and therefore protocols necessary, certifications, you need to onboard them. Like for example, for ourselves, we have had to comply not only locally with for example, the Data Protection Office, but also internationally with the likes of ISO 27001 on data security and IGDPR, which of course is an international organization. And most importantly, something that people also overlook is that when we talk about data protection, it's all about also people. For example, for us, we have weekly sessions where we take our people through what we need to do and how we need to protect, because that's actually the weakest point. It's not even the tools themselves, it's the people that use the tools. Unless there's any other I've missed out, I think I've mentioned about data protection as well as the how we inform policy.
All right, thank you. Thank you so much.
Okay, I want to respond to these questions quickly. Will AI bring laxity? No. And how do I know that? Actually, AI is empowering people to know what care they deserve. And why is that? Because they're able to get the information of what kind of care they should receive. During ANC visits, mothers should actually receive breast examination. We share that information with mothers, and some of the mothers are like, we never know this. But when they go to a facility, they can actually ask for that because they know. The question we have to answer is, how do policymakers and people in power, the AI that is moving around is responsible, such that it's not guiding people with the wrong information? That's a big question to answer. But AI is a support system, make people know their rights. Policy guidance on our work, yes, we have seen a lot of changes within counties because we share this data with counties and they make investments. One of the things that we have won, or one of the wins we have had recently is because our PROMS is in 24 counties, we don't have resources to go to all the 47 counties. So actually government is taking this up to be rolled out in all the 47 counties. And that's a policy level decision. Data protection, I think if you are sharing data with anyone, please, it's your right to ensure that authority or that institution is authorized by Data Protection Commission and licensed to do that.
Okay.
Thank you.
All right, thank you so much, Joy. Was there a question for you, Joy?
Nothing specific to me, but I just wanted to speak on the things to do with data protection. You remember at the end of the day, the owner of the data is the individual, you as the patient. So whatever information is being captured about you, whether in hospital or whatever system is being used, you have to consent. So the first place we need to make sure that we understand as individuals is what are we consenting that data to be used for, because we own our own data. Then the other thing that has been spoken about is being compliant with ODPC, GDPR, HIPAA laws, whatever is governing the type of information that is being collected and what it's being done with afterwards. I think most institutions have that set in place, but a bit of the responsibility is still left to the individual to know what happens next with the data.
Once you give. Thank you so much, Joy.
Yeah, I think I'll just probably supplement what has been said, but in particular the questions raised by Judy and Benjamin. Benjamin asked about, again, data protection. I think in Kenya we have a very good act, the Data Protection Act, but there is a supplement, the Digital Health Act of 2024. And what it really tries to define is three things. So one is authorized access. So who has authorized access to your data? So as a patient, someone going to a hospital, when you look at that consent form that you sign, there will always be a few categories of who you are giving access to that data. And aside from authorized access, what the ODP also has to do is sensitivity classification. So some data is not sensitive and it can be shared as far as a specific class goes. But sensitive data like patient's diagnosis, patient's imaging, patient's pathology, that's classified as sensitive, so it can't be shared willy-nilly. Maybe even your insurance company will not get access to that data even if they are authorized. And the final tenet is patient's rights. So all institutions that have, even if it's authorized access to that data, still have to act within HIPAA protection as well, that maintains patients' rights. And I think that's the most important thing. The one question that Benjamin asked for precision medicine. So as we tailor for example, the PSMA that you used, so we do have protective measures for non-target sites. And we do that by doing patient-related dosimetry. So dosimetry means calculating the dose that goes to a specific site. So that's what we do. That's why it's really important for us to do patient-specific imaging and planning. And there was a question asked by Judy. I think that's the last question, and it's very important because I'm a radiologist and a nuclear medicine physician, and I do use some AI-related tools in my work for either lesion segmentation, lesion planning, treatment planning for radiology. And one of the important targets that comes up is who takes responsibility for that tool. And current guidelines, like we've set out, is the person using the tool is responsible legally for the outcomes of that tool. So it ensures that there's responsible usage of these computer-assisted diagnostic tools. So there's no laxity for the professional, but there's also no laxity in the institution's usage or licensing of this. And the policies that we set up, and I think WHO has, one of the panels that I was in, was very important for us setting these guidelines that usage is limited to the personnel. Okay, thank you.
All right, in the interest of time, we will not do a final round of parting shots, but because we have really eaten into Dr. Diana's time and their panel. But thank you so much, ladies and gentlemen. Let's appreciate this panel for really great insights that you have interrogated on advancing healthcare excellence through digital transformation, data and analytics. And Dr. Diana is preparing for a panel discussion on world-class research, innovation and human capital for healthcare excellence. And they will be looking at strengthening research, innovation, training, and talent retention to drive excellence in healthcare delivery. So if you have more questions, please grab these guys before they leave. Ask all the questions that you have. But for now, please, let's appreciate them with a bigger round of applause, even as we take a very quick photo session, official photo session moment.
I know we're running behind time, but I assure you, you want to sit for the next section. We have professors on professors, people who work in research, academia, clinical practice, especially if you've been thinking about, I want to venture into science. I want to venture into clinical practice. I am already in clinical practice, but what's the next step for me, right? This is the panel for you. We're going to make it short, simple questions as we wait for the other panelists. We even have someone who is a specialist in traditional medicine, yeah, who will be speaking to us shortly. So keep your questions. We'll ask them one question, then we open it up to the audience for questions, yeah? We'll be starting off in the next, he's here. We've been speaking about you, yeah? But we'll start off with Dr. Jeremiah, who will be making a short presentation, then we'll go into the panel, yeah? Dr. Jeremiah Gathirwa is a Senior Principal Research Scientist at KEMRI and the Acting Deputy Director of the Center of Tropical Medicine and Drug Research. He's been leading groundbreaking work in natural products, nanomedicine, what is nanomedicine, and African drug innovation. He'll give us a short presentation, then we get the panelists on board.
Good morning. As introduced, my name is Jeremiah Gathirwa. I'm a research scientist based at the Kenya Medical Research Institute. For this presentation of the day, it's by DG who had been invited to come and give this presentation. But as you heard from yesterday's presentations, he's at the border point preparing for emergency response towards the Ebola outbreak. So I want us to change gears a little bit and talk about this topic. What we have been hearing before, the presentation that we've been having is all around the areas of conventional medicine. And I want us to change gears and talk about traditional medicine. The topic of my presentation is on harnessing natural products and indigenous knowledge for drug discovery. When you hear of natural products and medicine, what comes to mind is traditional medicine. And what is traditional medicine? I'm sure most of us know we have used traditional medicine in one way or another. And I can say that in this part of the world, when you hear of natural products and traditional medicine, what comes to mind is things to do with herbs, with medicinal plants, and how we utilize them in the healthcare system. Traditional medicine has been defined by the WHO as the sum total of knowledge, skills, and practices based on theories, practices, and experiences that are indigenous to different cultures, which are then used in maintenance of health in many ways, including prevention and mostly in the area of treatment. So we can go to next slide. And as I said, in this part of the world, what we refer mostly as tools of traditional medicine are mostly herbs, medicinal plants, although in some other parts of the world, there are other things that are used as natural products, including animal products, marine organism, and many others. But for us, for most of in this region, we normally, when you hear traditional medicine, what comes to mind is about herbs. And now the question here is, how do we harness this? Because these have become very common. Many people are using this source of this type of medications. So we need to, my topic of the day or my talk today is to demystify what is traditional medicine and what we are doing around this space. So traditional medicine I have described, maybe we can go to next slide. And they are not, we can say that traditional medicine has given us some of the conventional drugs that we use today. Just to give you examples, when you look at something like artemisinin, for example, it came from a plant originally. This is from a plant called Artemisia annua, and it was discovered by a lady scientist from China, and she actually earned a Nobel Prize for it. There are others, like even drugs, conventional drugs that are used for treatment of cancer. Some of The molecules used for cancer, like vinyl alkaloids, have had their origins from traditional medicine. They come from common plant that we use, like Madagascar periwinkle, the plant you are seeing down there. We are all familiar with that plant, and I don't know, maybe the compounds shown there are being hidden by the seeds here, but these are some of the APIs that are used in most anti-cancer products, and they come from a plant such as that one. Actually, as much as 40% of the modern drugs that we have today, they have been developed directly from plants, or plants molecules have inspired their development. Maybe you can go to the next slide. The WHO recognizes the growing role of traditional medicine, and that is why it is advocating for integration of traditional medicine under the strategy of 2025 to 2034. And actually in Kenya, the government is advocating us to transition to integration of traditional medicine by the time we go to the year 2028, which is about 2 years to come. And when it comes to integration, what we mean by this, it is a coordinated provision of safe, effective, sustainable, traditional medicine along mainstream healthcare. And what we are advocating for as an institute is for us to be able to integrate such, we need to have scientific evidence. So whatever we are integrating, we are sure that it is something that works, and it's something that is safe, and is also standardized. Maybe you can go to the next slide. And that is why, as I'm saying, scientific evidence is very key, because it is what forms the bridge between traditional knowledge and the national health system. And this is the space that, as an institute, KEMRI is really trying to come up with evidence, because it is evidence that will build confidence in what we are integrating. It builds regulatory confidence. That is, we can go to the next slide. This busy slide, allow me to take you to the lab. It's just to show you some of the processes that we take this research through when it comes to traditional medicine. First is documenting the indigenous knowledge, because this is knowledge that has been passed down centuries by the old wazers. You got this from your grandfather, you pass it to a preferred child. But what is happening is that we are losing most of this information. So as an institute, we are trying to document this information a lot. And then once we document, the next step is we are interested in knowing what are these plants that people are using as a source of medicine. So we undertake botanical authentication, identifying the plant. And then the next phase is what we call phytochemical profiling. This is to understand what is in this preparation. If it is a plant, for example, what kind of compounds are there? In traditional medicine, generally, we don't necessarily isolate to get the active pharmaceutical ingredient, the API, but these help us when it comes to fingerprinting or standardization, so that what you prepare today and you want to prepare another preparation, maybe a year to come, you can quickly check what kind of compounds are in your preparation, and you are able to tell that what you prepared last time and what you have now is similar. Then the other step is pharmacological evaluation. We have developed a number of screening models, both in vitro. What I say in vitro, I mean whereby you are culturing maybe a disease-causing pathogen, and then you use a drug, you do a drug challenge to see whether the preparation you have is able to inhibit the growth of that parasite, if it's a parasite, for example, or a disease condition. So we have both in vitro, which is the culture method, and we also do animal studies, whereby in animal studies we use small rodents such as mice, rabbits, which are a bit bigger, and even non-human primates with our collaborators, so that we are able to test this in a living organism. And that is what I'm showing them. And then the other thing that we do is about formulation studies, looking at how to improve the delivery of these natural products, and also the issue of quality control and clinical trials where possible. We have the capacity to do clinical trials under KEMRI, and we plan moving forward, we'll be subjecting some of this preparation under clinical trials. Maybe you can go to the next slide. And these are some of the key achievements that we have been able to manage in KEMRI. We've been able to evaluate quite a number of traditional remedies, looking at their safety, their efficacy, standardizing, so that as we get to close to the date where we are supposed to integrate traditional medicine, we are ready. We have preparations that we can be able to subject to that. Again, we have been hearing about adapting emerging technologies, AI, computing, and all that. I can say we have established quite a number of models that are able to help us deliver some of these products, like the use of nanotechnology, whereby you are able to achieve targeting. Maybe you want to kind of deliver your formulation into a specific disease cell using that technology. And also computer modeling, so that we can able to predict how these compounds interact with the body system. Can go to the next slide. This is another complex slide, but I just wanted you to appreciate the kind of processes that we take through. The first one is the simple methods of extraction, doing the simple safety studies. And then after that, we have the isolation and structural elucidation. Then we have what we are calling computer modeling pipeline, whereby we want to see target prediction. And then we have also molecular simulation with protein ligand binding interactions, and also just to understand the mechanistic action of these APIs, or the molecules that are inside this herbal preparation. The thing is, at the end of the day, we end up with a well-characterized formulation, even if it is coming from a herbal product. You can go to the next slide. I mentioned about adapting technologies, such as nanotechnology, for example. Just to give an example, this is a study we did on this compound, this preparation, from a natural product. We realized that from that natural product, we had natural polyphenols that were very good in targeting breast cancer cell lines in an in vitro model. But we also know in vitro model I mentioned is the culture method. But we also know that polyphenols suffers the limitation of crossing various lipid membranes, and also due to poor miscibility, and therefore you end up with low bioavailability. The other challenge is they are fast removed from the body through what we call fast-pass metabolism. And so using a nanocarrier system, we were able to kind of deliver these molecules, or this group of compounds, using what we call phytosomes, which is a nanostructure that is able to protect that preparation, so that it is able to reach to where it is needed intact. Yesterday, presentation from our good professor from Kenyatta University, she showed us how she's using targeting on skate care products. But for us now, we are using similar technology for delivery of drugs. Next slide. This is just a pictorial to show you some of the lab facilities we have in KEMRI. The first slide there, the first picture, shows you herbal gardens, one of the herbal gardens. These are areas whereby we are growing these medicinal plants to serve as field classrooms. We can teach people about medicinal plants, how to conserve them, and all that, and also serve as a raw material source for us for the pilot production of some of the preparation that are in research at the moment. And of course, the other laboratory setup is just to show you like the phytochemical analysis setup we use. We have a number of cell culture laboratories, BSL-3 and BSL-2 for this work, and other equipment to support these kind of studies. So far, we have been able to work on a number of preparations, and if you visit our booth there, you will be able to to see some of the products that we have developed, which are in preparation for the integration. Product like for prostate wellness product, something like for breast cancer, and even others for boosting the immunity for people especially with immunocompromised conditions. We can go to the next slide. And just to show you an example of some of the products that we have developed, very simplified products, but working in an amazing way. Like we have a product from a plant called Moringa oleifera. Most of us know it as a good immune booster. We have a product that is we developed for herpes simplex, and this one we were able to show that it's as good as what we have in the control, which is the control drug acyclovir, like a deworming porridge, a simple product, a product for hypertension, and even an environmental product for control of jiggers and others, of course. You can go to the next slide. We are now mostly concentrating on cancer product that can help in management of cancer, either directly being used or as support formulations, such that when you are receiving these cancer treatment, they help to mask the toxicity that comes with that kind of treatment. And this product, one is like the one shown there, which I described, that is a more refined product where you're using nanotechnology for the delivery, especially for breast cancer. And the other down here, also a good product for BPH. This is benign prostate hyperplasia. You can go to the next slide. And this is just to show other products, adjuvant products that can be used, especially for immunocompromised cases. You can go to the next slide. And for this product, we've been able to obtain some certificates for like KIPI, that is IPR, and also we have obtained trademarks for some of these products awaiting rollout. We can go to the next slide. And despite the work that we are doing, there are challenges. The first one being funding, because this is an area that does not attract a lot of funding. Most multinational would fund conventional treatment or research in conventional treatment, but in the area of traditional medicine is an area that is really poorly funded. And then the other thing is there is poor linkages between various stakeholders, because like researchers, maybe at Cambridge, we develop something, but for a medical doctor to prescribe that is a bit a challenge. There is we need to do a lot of advocacy so that we can talk in the same language on in this area. So the other question we need to ask ourselves is, do we have enough resources? Because you find that due to urbanization, deforestation, and even excess commercialization of these medicinal plants, you find that some of them are disappearing from our habitats. That's a plant like Prunus africana, for example. It has been really overutilized by traditional health practitioners. And even a plant like Mukombero, for example, which is called Modia witi, you find that people are really over-harvesting it. And we risk, there's a risk of losing such plants due to over-utilization. Maybe you can go to the next slide. But the new dawn, as I said, Kenya commits to integrate traditional medicine. So there is a lot of opportunity in this area. And we hope that we'll be able to get there before the target of WHO or 2024-2035. Key pillars here being that, one, we need evidence, scientific evidence. We need regulation, because this is something that is also missing. And also when it comes to integration, we need all stakeholders' collaboration so that we can be able to integrate traditional medicine as our desire with conventional healthcare practice. You can go to the next slide. And of course, I mentioned about the various advanced technologies that we are adopting in this space of traditional, complementary, and integrative medicine research, including like molecular docking studies, technologies such as nanotechnology in delivery, and also the importance of conservation, as I mentioned, whereby we need to cultivate some of these plants so that we don't lose them. As Africa, say we must lead in the next generation of phytomedicine innovation. We can go to next slide. When it comes to training, there is a very limited training in the area of traditional medicine. We are benchmarking with countries like China, who you go there, you find there is a lot of formal on how to use traditional medicine. And we hope that moving forward, we'll be able to get there someday. KEMRI recently got a charter as a degree awarding institution, and we hope that moving forward, we'll be able to develop a curriculum whereby we can be able to train people in this area of traditional medicine. Move forward. And that brings me to the end of my presentation. Thank you very much.
Thank you, Dr. Jeremiah. Santi, who knew? Who knew these products exist right here? They're being tested. So I want to, first of all, welcome my panelists on stage because of time. I know there are some questions. I've received some questions. You can ask towards the end. I will start off, and remember, these questions don't necessarily have to be focused on the panel discussion. These are renowned professors, these are research scientists who have the knowledge and experience. If you want to say, how do I want a career in the same, please feel free to ask. So as you're preparing for the panelists on stage, I will start off by introducing Professor Sam Kinyanjui, who's the head of training and capacity building at KEMRI Wellcome Trust Research Program and director of the IDEAL Initiative, a renowned scientist, mentor. His work in strengthening scientific leadership across Africa has earned him international recognition. Thank you. Yes. Professor Moses Obimbo, who actually was my mentor as well, is a clinical scientist, obstetrician and gynecologist. He's the chairman of the Department of Human Anatomy and Medical Physiology at the University of Nairobi, and he's a leading voice in reproductive science and women's health. He'll be talking about what is translational research as well. Dr. Lista Osongo, who's the CEO and registrar of the Nursing Council of Kenya. There are quite a few questions for you already. She's an accomplished academic and healthcare leader, championing excellence in nursing education, oncology, cancer, and health workforce development. And last but not least, we have Dr. Damaris Matoke here, who's a senior principal research scientist, I told you, research scientist at KEMRI and a national leader in genomics, precision medicine, and has been advancing cutting-edge research and health product innovation in Kenya. Can I get a round of applause for my panelists? I know there have been some very big words that have been mentioned, even when Dr. Jeremiah was talking about phytomes, and people are writing to us saying, can he simplify? I think we're going to start off by just understanding the work that the research scientists and innovators who are ahead of us, in front of us, what do they do? So I'll start with you, Prof. Sam. Yeah? You have been a mentor and you've been in this field for decades on end, so to speak, right? The question here is, what first inspired you to pursue a career in research, and what keeps you motivated to date, despite the decades?
So normally when people answer this question, they say, I was motivated to solve social problems, bring solutions to the community. But actually I was motivated because I have a really strong curiosity in how things work, whether it's in biology, physics. Right from when I was young, I was always reading, trying to understand, to get a better sense of the phenomena that we observe. How do they operate? What is the mechanism behind them? And then on top of that came the interest to actually then use that curiosity to provide solutions to questions that affect us. I had a big interest in biology and therefore then went on to do into a career in biomedical research. I think.
What keeps you motivated today? That's what's made you start. What till date?
Yeah. No, first I must say, science is really exciting. I know for a lot of people, sometimes they'll feel like, oh, science is so hard. But if you go past the jargon, most of us here, I mean, you have a mobile phone in your pocket. And you're all really excited when there's a new mobile phone, maybe that has come out. You have a TV at home. You have a car, maybe some of you. And all those are products of science. And when I see those solutions coming through, every day, when you go to a hospital, what are we using? We are using science. That's what is driving us. I know the caricature of a scientist is often when we think of a person in the lab, some old guy, maybe looking at a petri dish or through a microscope. But basically, our whole life today is built on science. The clothes you're wearing, the materials, those material science, the houses you're in, the physics and the engineering science. So I'm excited because I see science as really providing the solutions to all the challenges that humanity faces. And for me, I'm really excited when I see that happening.
I'm sure someone has had you and said, maybe there's hope for me.
There is a lot of hope.
There's a lot of hope. Prof. Obimbo, you straddle the clinical field and still in science, right? Or translational research. Perhaps tell us what has been your journey and what is this translational research?
Right, thank you very much, Dr. Diana, and good afternoon, everybody. I'm very excited to be here amongst the young scientists, the young communicators, the young people, very inspiring. Makes me feel younger. My background is in obstetrics gynecology. So I'm an obstetrician gynecologist. I practice about 40% of my time, but then the rest of the time I spend in science, and my science straddles between basic science at the discovery level, all the way to implementation science. So we do some work on what we call postpartum hemorrhage, women bleeding after giving birth and they bleed to death. Now, the aspects of medicine, practice, and science is sometimes quite complex because we have scientists who do work on the bench, and on the bench means we discover new molecules, we discover new pathways, we discover new biomarkers that are going to be significant in terms of treating. But those biomarkers found at the bench are not able to be impactful if they are not translated into actual policy or into actual action. So then we need to know how do we translate that research, the basic research from that bench to that research affecting the clinical outcome of the patient. So we say we discovered the molecule, then we did the clinical trials, we tested and we verified that these molecules are able to work. We developed some very basic tools like screening tools or diagnostic tools, and then further we developed clinical guidelines. But that's, we have the levels from T0 to T3. Not enough. For it to be sustainable, we have to be able to implement, make sure that we are able to speak and integrate our discoveries, our innovations into policies so that they are repetitively practiced and save a woman, for example, save a mother, for example. So I discovered just by working on the bench alone, you probably will do some work, but then the patient will still die without necessarily having this work done. And it's for that reason that we started an initiative for us to save mothers for the killers that kill them every day. For example, in this country, we lose about 5,000, 6,000 women every day, every year. And out of that, about 3,000 are lost because of excessive bleeding after giving birth. 3,000 women are very many. We have policies, we have guidelines, we have the protocols, but we are still not able to save these lives. So what do? we need to be able to integrate some of the things that we do into actual care. It's for that reason that our NPPH initiative started the advocacy work, communicating work, making sure that everybody understands this problem. We started the first ever global postpartum hemorrhage run to sensitize the communities. So it's not a medical problem, it's a community's problem. And when the community buy into the problem, the community is able to offer the solution. And we are very excited that we are moving towards solving maternal health challenges because of translating research into advocacy and into policies that are sustainable for saving women's and other people's lives.
Absolutely, and thank you for that. It shows that it's not just, as you're saying, remaining on the bench. It's also the practical, looking at it, because most people would ask, yes, you do all this work, but how does it help ordinary Kenyans, right? Most people would say, we do a lot of research. They remain either in the shelves, they remain in conferences, and we don't seem to translate it. Maybe just a follow-up question for you, right? What would you say is happening currently that will move the shift beyond the work that you do? What are you seeing from professional circles that you're moving from, educating, or rather research, we're now moving into policy? Is there any other work you're seeing?
Sure, thank you very much. What's very hopeful is that the African scientists, we're doing a lot of good work when it comes to discovery science, bench science. So we're able to innovate new molecules, we're able to innovate new pathways that are potentially going to save our patients. However, what's been lacking behind is the issue of communicating the work that we do effectively and communicating in a way that this work is able to impact and influence the policy makers. Because the policy makers and decision makers want things that are very clear, easy to understand, very practical, feasible, budget friendly, and of course have some form of public pressure for them to be able to get this into action. So what the African scientists now doing is learning how do we communicate the work that we do on the bench to the decision makers so that they're able to have their budget aligned towards getting that solution in place. Their budgets aligned towards getting that implemented. And I'm very excited to note that both the medical people, the research scientists are now communicating their work effectively, and some of the medics who've been practicing now are in the media and are able to communicate our work very effectively, like Dr. Diana here, which makes it very easy because then we're able to granulate these issues and make it very practical for our population. And then the work then moves just from the bench all the way to being implemented and to being into a policy integration framework.
Thank you, Prof. We want to turn to Dr. Damaris here because I've already been asked biotechnology. What is that? Is that it's too complex a scientific term. So for someone hearing it for the first time, what is biotechnology and how does it already impact the health and lives of ordinary Kenyans? What do you do?
Thanks a lot, Diana, for that question. As the word goes, biotechnology. Biology, I know if you are Kenyan, you've done biology in school somehow, or it was there and you have schoolmates who did biology. So biology is study of the living organisms. So it's using living organisms, understanding these living organisms to be able to use now technology to provide solutions. And solutions can be in different ways. They can be diagnostics, they can be drugs, they can be just understanding the environment or understanding how the body is responding towards maybe a condition, be it a disease. Even when you're health, it's important that we understand in case you're faring on this way, what technology or what tools we can use to understand when things fall differently. So it's a study of using biology or living organisms to be able to develop products and solutions for human health, but also it's applied not only human health, but also in agriculture, it's also in animal health, even environmental health. Yes.
There's going to be a follow-up question around that, but let me switch to Dr. Lisa. You are regulator, you're the CEO of Nursing Council of Kenya, right? Many Kenyans already interact with nurses every day, right? But many may not know about the Nursing Council of Kenya. Again, what is your role, and how does the council help ensure that patients receive safe and quality care?
Thank you, Dr. So for the Nursing Council, we are a regulator. We are the ones who license and register nurses once they qualify from training. We also regulate the training from basic level, so diploma, certificate, and also up to the postgraduate level. And we also approve curriculums that can be used for training. We do also approve facilities where the training is taking place. And we also do conduct compliance audits in those facilities and the training institutions to ensure that they maintain our standards. So in terms of licensing, we do take our nurses through a licensing exam in order for them to be entered into the register. And we also expect them to do continuous learning so that before they renew their licenses, so that we ensure that they are practicing using the latest information, they are still maintaining their competencies, and they are assuring public safety.
We already have a question around. We have a lot of cases, and this is still for you, Lister, that we have a lot of cases, obviously, of fake healthcare practitioners, right? And unlicensed clinic and so on and so forth. What practical steps can Kenyans take to verify, and this might not even sit to the Nursing Council, but to verify that either a healthcare professional or training institution is properly accredited, and what should they do if they suspect fraud?
Thank you for that. We do, if you visit our website, we do have a list of all the accredited institutions on our website. Of course, there are new programs that are coming up. We are yet to update that, but that is the first place you can check. You can also report any suspicion of somebody faking their credentials to the council. We do have a whistleblower policy if you don't want to be known who is reporting. Again, you can also double check the license of the individual in our website. So it is very straightforward. Alternatively, you can call. But we do have all that information on our website, easily accessible to the public.
Thank you. And just on the same line, Dr. Jeremiah, there's been a question around, now we understand that there are products that are accredited through KEMRI. But what if I came across a treatment or a product that I think is fraudulent? What would be the process of reporting? How do you even tell that this is genuine versus not?
Well, thank you for that really nice question. Well, we have, for one, let me correct you. KEMRI is not a regulator per se, so we don't accredit products. But the products that we interact with, or maybe from our stakeholders and even from ourselves, the people who are responsible in the regulation is the Pharmacy and Poisons Board. And in the Pharmacy and Poisons Board, they have a portal whereby you can be able to identify products that have been regulated, which have been approved, either whether they are conventional or even alternative treatments. We have quite a number of those which are already listed, but unfortunately most of those that are listed under the Pharmacy and Poisons Board portal from other countries. Like we have quite a number of products from India and many others from China, but very little or very few from Kenya per se. And that is the platform that probably can tell you which are these products that are approved and which are you can be able to identify them from that portal.
Absolutely. Pharmacy and Poisons Board. If you have questions, we will pass the mic. I'll try answer some that have come in. I think this is to Prof. Sam. Why, and it's a direct question, we have talented minds, but why do many talented African researchers leave? And what will make them stay?
Great. And I think this answer applies not just to science or the science sector, in many sectors. And essentially there are a number of reasons why people leave, and it's true. The work I do, we have been training literally now thousands of Kenyans into research, and we have amazing people. They can compete at any level, at international level. But once they have trained, and you've provided really high quality training, for example, in places like Cambridge, they're expecting then to work in similar environments. And in addition to issues of, for example, remuneration, a bigger issue is the ecosystem itself in which you work. You've seen the sort of science that, for example, Dr. Gadhiru was talking about. You need access to that sort of infrastructure. But sometimes it's not just the infrastructure, it's also the support mechanisms, the operational mechanisms. So let me give you an example. You may have a question and you need to utilize a certain equipment or even reagent. Reagents are the chemicals we use. If you're in the UK, you retail order that reagent in the morning, and by midday, it's come to your lab. So I've spent some time in the UK, so this is practical that I've seen and experienced. You have the same question in Kenya, and you require the reagent. It takes you 6 months sometimes. And it's not just because we are not finding it. You're buying it, you're importing it, but the whole process of that reagent coming from the UK or from Germany or from wherever else and coming all the way to Kenya to the bench where you're working sometimes takes 6 months. It's not competitive. And so we have this talented person who wants to contribute, who wants to generate world-class science, but they can't do it in this system. And so there is a gap there in the ecosystem, the supportive aspects. And sometimes people think that people live just because of remuneration and money. A lot of times it's not about money. It's being able to do what you'd like to do in the most efficient way.
It makes a lot of sense. Questions, if you have questions, I'll be doing one more round with the panelists. Then if there are any two burning questions, I'll take them. This is for Dr. Damaris. You've spoken about products. Can you give us examples of those products? And I'll add on a question to that around what this example of products, right? Are they from Kenya, right? Or are they, essentially, I think what they're essentially asking is, do we have examples of homegrown products, right, that are in market that you can point us to that are really improving lives now?
Quite a great and challenging question. Yes, at KEMRI, we've done a lot of research and we've been able to come up with innovative solutions. Some of the products being, like when there was COVID, you could see there's a sanitizers that were being used. Among such products, we have diagnostic kits. We have diagnostic kits for malaria. We have diagnostic kits for RVF. We have, that's Rift Valley fever, which is one of the arboviruses. We have some diagnostic kits that are used for HIV testing and also hepatitis. I will say this is just a drop in the ocean. I think there's a lot more. And some of the products that my colleague, Dr. Gadhiru, talked about that come from traditional medicine angle, among them being the porridge, etc. I'll say these products exist at KEMRI. They couldn't, maybe you might not walk into a supermarket and find them, but if you come to KEMRI, you should be able to have access. So there is a stage that they are yet to get into, mostly into an open market for use. I wanted to add that the challenge that leads for us not having as many products in the market, it's because we don't invest enough. There's not much investment in that comes in, especially in financing, that comes into supporting research and more so innovative research that leads into product level. I want to indicate that in Kenya, especially even Africa in general, we don't lack brilliant minds. What we lack is investment on utilizing these brilliant minds, or people, because we have so many scientists who've come out of universities, or people who have entrepreneur minds who come out of universities or who are in our institutions, but the funding is not locally. We don't have domestic funding that supports product development or innovations. So you find, as we call, whoever pays the piper calls the tune. Most of our funding is external, so we are funded externally. So we are able to do so much. So there are so many innovations that we are able to churn out, but we are stopped at a certain level because we are not able to move it from just a discovery level to market level or to products which can impact the communities. So I wanted to bring in that point of, can we ensure or even call on governments, local government, to invest in R&D, innovations, product development, not only just from ideas, but also just ensure that they have gone to the market and people can have access to them. To just finalize on that is that, remember, if we have brilliant minds, we have good ideas. But if they are not facilitated, they will be taken out. And that's the question that Professor responded to. Someone will identify that brilliant mind and will be used in another country. And also, if we don't invest in these good ideas, there will always be just, ours will be a scientist to publish. And once we publish, that is it. Someone else will take that and commercialize it. So, and then we'll buy those products very expensively from out there. So it's extremely important to know that we have the capability. We don't lack talent. We have talent. The only part that needs to come on board is investing in the talent. Thank you.
Dr. Gadira, you want to respond?
Yes, just to add a point to what my colleague has said. When it comes to traditional medicine and alternative treatments, yes, we have done research on a number of these products and we have done pilot production. But why you are not seeing them in the market, one thing is policy. At the moment, we don't have an approved policy that can allow integration of traditional medicine into mainstream healthcare. And this policy, why it is so important, it is what will guide how, like when you walk into a hospital, how will you be treated? If in case you prefer to use traditional medicine, is there a document that can support a practitioner to give you that traditional medicine? And those are steps that we are learning from other developed countries like China, whereby they have done a policy that guides all that, referral mechanism. Maybe you are coming from a traditional healer and the traditional healer want to refer you to a hospital. So the mechanism of referring are not there. And this is what the policy will address. I know the Ministry of Health is working very hard on making sure that in the near future, very soon, we are going to have a policy guiding that. Thank you.
Prof. Sam, you had a point to respond.
I would like also to maybe disabuse a bit of a view where the understanding of the output of science and biomedical research, for example, is always a physical product in a pharmacy or in a hospital. If you think about the pipeline of health, there are many factors that impact on health. There are social factors, what you call social determinants of health. There are system factors, how our health system, our governance structures are set up. There are cultural factors, there are education factors, and so not all researchers, and I want to emphasize on this because there will be people in the audience, students in the audience who are thinking, I can't be a researcher because I am not interested in lab sciences. It's just by coincidence that we are all from lab. But actually, a very large part of health research is not necessarily laboratory research. There are people who are interested in understanding what social factors impact on health. So if you're a student undertaking social science, anthropology, we really need you there. We want to understand the spread of disease, what we call epidemiology in technical terms. Where is that disease? How is it being transmitted? Which population is being most affected? At what time of the year is it happening? And a lot of that is not necessarily people even who, we are talking of geographers, we are talking of people who can use mathematics to do what we call modeling, we are talking of engineers who are using GIS, Geographic Information Systems, to show locations. So again, it doesn't have to be people who did biological or medical sciences. We have a lot of people now from IT, from computing, we're talking about AI in health, and data sciences, the people who help crunch the data, again, not necessarily coming from the biosciences side. And obviously planners. Where should the county put a hospital? Where should the country put a hospital? Where should you be sending doctors and nurses? All these are people who are not necessarily coming from the biosciences. And the products that they will generate will not necessarily be compounds or tablets in a pharmacy. They will generate data that will be used in prioritizing resource allocation. They'll generate data, I don't know, on nurses, patient ratios. They'll generate maps for where the country, where we should be prioritizing, where there are hotspots, and also generate data on when we can expect a surge in healthcare demand, because maybe that's when malaria raises. So I think it's also important that we don't keep asking, where are the products that the Kenyan scientists are? A lot of the work that the scientists are doing will not end up there. But I can give you a practical example. If you took the malaria treatment guidelines, the booklet that doctors carry pretty much around the world, about half of that or a bit more is work that has been done by primary scientists. If you look at the use of bed nets, I think a lot of us here know about insects like bed nets. The three main studies that led to the adoption of bed nets as the key tool in the arsenal for fighting malaria, one of those studies was done by Cambridge scientists. It's not a product, the bed nets were not the product of the scientists themselves, but that is the data that drove that sort of policy. So yes, there are other outputs that are not necessarily physical compounds in a pharmacy. I just wanted to emphasize that.
Absolutely, and I guess I'll go to parting shots, and I'll start with Dr. Lister over there, because as your parting shot, there's also a question that came in that asked, does the Nursing Council support nurses who are looking for jobs overseas, right? I know it's a loaded question. You can answer it with your parting shot.
Thank you, Dr. Well, our mandate is to regulate nurses and midwives to ensure public safety. However, we do play a role when it comes to nurses planning to migrate outside. We do the verification in collaboration with the other nursing boards or councils from other countries. So that's how we facilitate. But our mandate does not allow us to seek employment for nurses. So that is done by other agencies. We have a Ministry of Labor, and there's a National Employment Authority that is responsible for that. But specifically for nurses, I see most of them migrating on their own without going through government. There are a lot of agencies that are recruiting nurses. So our role is purely to verify that this is a qualified nurse. And I'm proud to say that most of our nurses graduate ready to go and work anywhere in the world. So my parting shot is that I want to agree with Prof. that we need to remember that knowledge is also a product of research. Especially for us nurses, most of the research we do is to try and see how we can improve patient care. So that is also a product that helps us ensure that we provide quality care. Thank you.
Thank you. Prof. Obimo, parting shots?
Thank you very much. My parting shot is very simple. By show of hands, how many of you believe women's and maternal health is important? Okay, almost everybody. How many of you believe that women's and maternal health affects the health of the generations to come? Right, my final one. How many of you believe it's worth fighting for women's and maternal health? Kindly join us in the fight so that our women, our mothers are safe and our children therefore will be safe. Thank you very much.
Thank you, Prof. Dr. Damaris?
Just to ride on that, I think for science, research and development should thrive, it's important that we consider inclusivity. So for me, is to call on all those girls out there, those ladies, those women who feel that science is for the boy child, is only for men, or is for people with muscle, to just join in the fight, because it's we will be able to get perspectives or perceptions both from the boy child and the girl child. So as we fight for maternal health and child health, it's important that also women are part of the solution. So we are part of the delivery or part of developing. And we need to reshape the question around science. We need to reshape. I'm using reshape because already there's platforms or structures that exist, but it needs to be very inclusive. So we need to invite all of us to be on board, so meaning all gender, the women and male, to be on board so that we thrive science and produce solutions that matter and affect our communities positively.
Thank you, Dr. Jeremiah. Parting shots?
I will limit my parting shot in the presentation that I made about traditional medicine. All of us know about traditional medicine. You know what is traditional medicine, or you have used traditional medicine in one way or another. Maybe we can show by hand. No. Okay. Most of us have used traditional medicine.
Dawa, is dawa traditional medicine? If I do onion, is that traditional medicine?
Yes, dawa is traditional medicine, and as I said, these are some of the concoctions that we used a lot, especially during the time of COVID-19, and they worked on us. So that is dawa is traditional medicine. So my parting shot, I would say that for this region, we have enormous potential to use traditional medicine in advancing healthcare. Africa is one of the most diverse regions in the world, whereby we have thousands of traditional medicines. And if we tap this, if we harness these resources, we can be able to make available affordable healthcare, and we can also be able to create jobs. As I showed in my presentation, as much as 40% of the conventional medicines we have today, they have been inspired by traditional medicine. So it is an area that we can tap into and contribute significantly in our healthcare system. Thank you.
Thank you. I know we have a lot of questions, and I'm hoping you can stick around because we do want to hear from Dr. Richard Lesiape of Kenyatta National Hospital. The panelists, some will remain. I know there are urgent questions that we can also forward to them. But for now, panel, I want to say thank you so much. You have inspired. There are people here who are saying, I want to be like Dr. Damaris, prof. Both profs, yeah? Dr. Lister, Dr. Jeremiah, thank you so much. Asante sana. If there are questions, we will handle them after this. Yeah? We'll stand here for a photo as I introduce Dr. Richard as well. Asanteni. Yeah? Dr. Richard, thank you so much for being patient with us. Dr. Richard Lesiape is the Chief Executive Officer of Kenyatta National Hospital, which is Kenya's largest referral and teaching hospital. He's a seasoned public administrator and healthcare leader. He made history in many forms. He was previously Principal Secretary at the Ministry of Environment, Agriculture. He's been the CEO of Jaramogi Oginga Odinga Teaching and Referral Hospital. He has a PhD and MBA. No one better to educate us. Dr. Richard, karibu sana.
Yeah, good afternoon, everyone. Habari zenu? You can hear me? Okay, thank you very much. Yes, she has said my name very well, but it is Lesiambe. There is another one, a better one, Leresian. So now it gives me great pleasure to be here this afternoon, and I want to start by sincerely congratulating the Nation Media Group. I want to salute you guys. You have decided to influence our Kenyans in a positive manner, and particularly for bringing us and bringing these great men and women, to appreciate what happens in our health sector. Nation Media has done us proud in so many ways, either through the print media, through the TVs, radios, and all these other channels. I want to congratulate you and thank you and give you the encouragement and the inspiration. Continue doing this. Inform Kenyans, inform the world, inspire us so that we get information and knowledge. Knowledgeable individuals, knowledgeable citizens are very, very powerful. Now, I come from Kenyatta National Hospital. I have a small team from Kenyatta National Hospital. Kenyatta National Hospital is the second largest hospital in Africa in terms of bed capacity. We have 2,200 beds at Kenyatta National Hospital, where we have patients every day, 2,200 sleeping there. When things become difficult, particularly when we have got industrial action within Nairobi or Nairobi hospitals, or when we have, Kajiado or Kiambu, the hospitals, going on a slow or industrial action, we have sometimes even up to 2,500 patients. The largest hospital in Africa with the highest number of beds is Chris Hani Hospital in South Africa. We are also very proud to have the largest number of specialists. We have 250 of them from Kenyatta National Hospital, and we have 188 of them from the University of Nairobi. We are also very proud to be the hospital with the University of Nairobi, which has trained almost 15,000 Kenyan doctors, and also trained not less than also 1,000 African doctors. We are very proud to have all those doctors, majority of them, 10,000 of them in Kenya, and about 4,000 to 5,000 of them in the US, UK, and other parts of the world. We also train specialized nurses and specialized healthcare providers. Nurses who handle nephrology come from Kenyatta National, so they are trained there. Nurses in critical care also come from that great hospital. So we are very, very proud to be the apex of healthcare in our nation. We are very, very proud to have the best doctors, the best nurses, the best healthcare workers, most skilled. And we are saying that we have existed for 125 years. We were started, or this hospital was started in 1901. Today, 125 years, we have never closed our doors to Kenyans and to Africans. Even during industrial action, even during strikes, we don't close those doors. We still have specialists, we still have consultants, we still have critical healthcare workers who provide those services. So to me, one thing I want to say is that we are very, very excited to see that we are saying we want to position East Africa as a center for healthcare excellence. And the only way we can do that is by supporting, the national referral hospitals, besides, of course, other facilities we have. In the national level, we have national referral hospitals. There are about 7 of them. Kenyatta National Hospital was the first one. We also have Moi Teaching and Referral Hospital in Eldoret. We have Kenyatta University Teaching and Referral Hospital. We also have Mwai Kibaki Teaching and Referral Hospital in Nyeri. We also have the youngest kid on the block, Jaramogi Oginga Odinga Teaching and Referral Hospital. I think we also have Mathare, a mental health hospital. Those are the national referral facilities. And for us at Kenyatta National Hospital, we are the skills and the competencies to make Kenya a center of healthcare. The recent past, I think the few months, I think we have seen what has happened there in the last few years. We have had, for example, recently, a young boy, 8 years old, Brian. This young fellow was actually shot by bandits in Isiolo, somewhere near Meru. And he lost his jaws, the whole face, the nose, and the mouth. The young man could not go to school. They had to cover that face. Refused to went to school, was being laughed at, and he could not leave. The mother, the husband had to leave the mother. Our doctors at KNH, multi-speciality team, decided to come together and did a reconstructive maxillofacial surgery. That young boy, Brian, today has a face, has a nose, has a mouth, and is back to school. And in fact, the mother is actually working for us at Kenyatta National Hospital. That maxillofacial reconstructive surgery is actually one of the best in the world. Probably could have taken that boy to India or actually, for example, to Europe. But we did it here. We have the capacity, we have the skills, we have the competencies, and we have multidisciplinary disciplines that can do that. We had a young girl from Ukambani, at 19 years old, and her breast grew because of a disease, gynecostomasis. I'm not a medic, so you can help me feel the rest. It was gigantic. 20 kilograms of breasts. Our consultants, our doctors, our nurses participated to reduce that to normal, and the girl is back to school today. We have the capacity, we have great surgeons, specialists, University of Nairobi, KUTRH, MTRH, who for the first time in Kenya did a miracle that was being done by Jesus Christ in the Bible, according to the book of I think it was Matthews, where Jesus said, "Those who cannot hear, come to me." And we did 50 children by implanting cochlea, making them to hear for the first time in their lives. And we did it at Kenyatta National Hospital and MTRH. All those children now are growing to come and hear. We have done 300 kidney surgeries in this country, in that great hospital. So what I'm saying here is that liver transplant is one way or one thing that we have not done in our nation, and we are ready to start probably before the end of this year, that those who have got liver conditions will actually be treated at Kenyatta National Hospital and even some of our national referral hospitals. Bone marrow transplant. This is a very serious disease that affects our patients and Kenyans, particularly in the western part of our country. Kisumu, Migori, western Kenya, and also West Africa, Ghana, Nigeria, and the rest. All those Africans who are faced by this condition come to Nairobi on transit, either to the east, to Asia, or to Europe. We are saying before the end of this year, we as a country, we are going to ensure that we are going to perform all those procedures so that we can make Kenya, the hub or the center of healthcare services. Therefore, as I conclude, I was supposed to come and say one or two things here about our referral system. And I want to say that our Ministry of Health, the government of Kenya, has a categorization method of how our hospital systems work. We have the primary health care, which is indeed level 1, level 2, and even up to level 3 to 5. That's where we are saying we have people to call community healthcare providers, CHPs. Those are in every village in our country. They are in every ward in our country. They are in every county, and these people are associated with an hospital. I was in Jaramogi Oginga Odinga Teaching and Referral Hospital as a CEO there. And if you go to Kondele village, you have got about 150 of them. You go to Nyalenda, you have also another 150. They are all tied either to Lumumba Hospital or to Jaramogi Oginga Odinga Teaching and Referral Hospital. That system has worked and assisted us. These are the people who help us on promotive healthcare, curative healthcare. These are the individuals who will identify mothers who have got, maybe hypertension, before they go for delivery. These are the people who can identify those who are sick. These are the people who can identify those who have got certain conditions and assist them to move to the health centers or even move to other referral facilities. So the dispensary is also at level 2 and level 3 or health centers. That's also what's expected of us, that we go there before we move the next one. Then we have level 4 and level 5 hospitals. Level 4 and level 5 hospitals also are hospitals which have got theaters. These are facilities that manage conditions that cannot be managed at the primary healthcare levels or the dispensary levels. And what's expected is that with that referral system, that those who have conditions that cannot be managed level 5, they are the ones now referred to level 6. That is the MTRH, the KNH, and what have you. So the system, the referral system, is a very, very important system to help us provide quality healthcare in our nation. And therefore, the Ministry of Health, our ministry, is doing everything possible. It has a draft already. It is just a matter of getting public participation so that we can conclude on that national referral system. However, for us at KNH, we have our own referral system, particularly with our hospitals. It happens that all the level 5 and below hospitals are under the county governments. Work under the county governments. The governors are responsible for those facilities. The employees are paid and managed by those counties. But level 6 hospitals are under the national government, under the Ministry of Health, under Afya House. That is now in the public sector. We also have level 5 and level 6 in the private and faith-based sectors. In Nairobi, for example, Aga Khan Hospital, Nairobi West Hospital, and they are also at level 5 and level 6, though we call them sometimes level 6B, while the public ones are called level 6A. They also play such a critical and very important role. So, one thing as I conclude, if we are to provide efficient and quality healthcare, our referral system must be resilient. Our referral system must be efficient and effective, and it must be respected. I want to use the word must. That is the only way we can deliver healthcare properly. Because the experience we have is that we have individuals, we have patients who necessarily should have actually gone to a health center, who should have actually gone maybe to a level 4 hospital, but they deliberately walk to Kenyatta National Hospital. They deliberately walk to MTRH and demand for services. And being public institutions, we cannot send anybody away. But it causes us, sometimes some challenges. What we require to do is actually to enforce the referral system. I can tell you for free from other experiences. In the US, in the UK, the National Health Service System, every citizen, that is the UK, Australia, and even now, as I know, Rwanda, you cannot go to a national referral hospital if you have not been referred from a lower level hospital. And therefore, every citizen must be given an hospital to attend to, a clinic to attend to, a healthcare to go to. That you go there, that's your first point of contact with the doctors. And you are even given doctors, they are called GPs in the UK, general practitioners. They are the ones who treat you. When they realize that your condition demands higher level, they are the ones to refer you. And they refer you from that level up to the national referral hospitals, where we have got specialists. So if that system can work, it can really give us enough time. It will also give us resources to manage some of these most complicated conditions. Conditions at Kenyatta National Hospital, the patients who come there, the doctors whom we have trained with specializations, for 10 hours.